and move on. 5, 6, 7. Matt?
Yeah, just pick up the end-of-life model as matters arising, if that's right, Matthew. Can I do that now?
Yeah.
Just a brief update to the governing body. So the model we approved in September is progressing well. Really good clinical discussions underway about the nuts and bolts of it. And I'm a little reluctant to nail colours to the mast given how much things are changing with COVID at the minute. But certainly pending any COVID issues and the recruitment that we're expecting, we anticipate and hope really that the service will be up and running for April 2021. So by that point, we should have a really, really great service in place.
That's good news. Thanks very much, Matt. Anything more from page 8? Page 9, 10, and 11. Okay, subject to those that one amendment as suggested by Jeanette, then we'll accept those meeting minutes as correct. We'll move on to the second set of meeting minutes, which was the joint meeting. So page 1, 2, 3, 4, and 5. Okay, thanks very much, colleagues, for going through those with us. And I think it's probably would be remiss of me not to note that our normal minute taker Andy is not with us. He's unfortunately off unwell at the moment. So Jane Layton is taking the minutes for today's meeting. Just noting that that change of faces or at least initials around the virtual table, so to speak, today. Okay, so I'm going to move us on to the next item on the agenda then, and that's the question time. We have had one question submitted in advance from Peter Bauer of Health Watch, and Peter's question is, with the increasing power being given to the integrated care system in the region, what effect will this have on local commissioning and the locality aspects of the CCG? Which is a very good question. I'm sure Peter will probably recall having some discussions around the Health and Wellbeing Board table about this in the not too distant past. And I'll ask maybe Neil to try to answer that question.
Okay, thanks, Matthew. I mean, the first thing to say is there is still a lot of unknowns of exactly what increasing powers, or indeed statutory powers or responsibilities, ICSs will have. That is still yet to be determined, and we're expecting an NHS bill in the first half of next year, which should lay that out. So a lot of this is supposition at the moment. But what is absolutely clear in anything that I have read is that it is very, very, very important to maintain place-based decision-making, to keep decision-making close to local communities, as the NHS possibly is going to go through another restructure, which will be on a larger footprint. The way in which we're looking to do that is to work much more closely together with the local authority in how we commission services, so we can commission not just for people's illness, if you like, but generally for their health and the wider determinants of health. And we in South Tyneside are really well progressed along that line. I've checked out our direction of travel with very senior leaders in the NHS to make sure it is in line with current thinking, and it certainly is. And there are lots of examples around the country where local NHS commissioning is effectively joining together with a function of local authorities. So I think the vast majority of health decisions that really matter to local people about their local community services will still be in their local communities, despite what happens with an ICS. I think ICSs will be very much about some of the larger statutory functions that we have, and possibly looking about how we provide very high quality hospital services across the region that are fit for the future.
Thanks, Neil. I hope, Peter, if you're watching, I assume you are, that's answered the question appropriately for you. I haven't had any other questions submitted in advance by email. We do have people watching the CCG inbox during this meeting, so if there are any other questions that members of the public feel that need to be addressed, please do so by sending an email to the generic inbox, and we'll try to address as many of those as we can at the end of the meeting if that's possible. Can I then move on to the next formal agenda item, which I think is Neil and the Accountable Officer's information and update.
Thanks, Matthew. Yep. So this is just my standard report for governing body of the activities that I've been doing since last governing body. I don't really intend to go through it in any great detail there. There's some feedback from the joint committee meetings. I was unable to be at the one on the 12th due to myself actually catching COVID. There's some update there about the ICS management group, and there is another ICS management group this coming Friday. The details of which will be in my next report, but there's some details there about, again, how we progress and develop the ICS a little bit further, and indeed Matthew's been involved in the appointment process of the ICS chair, which is still ongoing. There's a little bit in there about COVID vaccination, just to give governing body reassurance that I'm quite involved with this, both in the ICS, in the North Eastern Yorkshire region and nationally. We have agreed in the ICS to use our flu governance structure in order to oversee the rollout of the vaccine, working very closely with Newcastle Hospitals, who've got the lead provider role in this area. There's a lot of understandable media attention with the vaccines that are currently on the stocks are still awaiting formal approval, but the NHS will be ready to vaccinate from the 1st of December. That's not saying we will get vaccine then, but we will be ready when the vaccine comes from that date, and I'm really confident about that. Something about the flu campaign. There's a real opportunity in these last few weeks to have a big push on the flu campaign. We are hoping to maybe do a little bit of media next week to try and do that. But the achievement in South Tyneside has been fantastic. Probably our best year. And I think it's been delivered really, really well within South Tyneside. So I think we can be quite proud of that. There is papers today about how we work closer across with our neighbouring CCGs, and we've had a number of meetings, and we continue to have our executives in common, which are improving with time. It's like whenever you bring two executives together, it is the meetings are often overrun, but as we're starting to get to know each other, I think that's going to be a really positive step for the CCG. A little bit in there about our plan in phase 3, and this is about maintaining elective activity. About 95% of elective activity, what we would normally expect to be done this year, is now being delivered across our ICP, despite the rising numbers of COVID. So I think our local FT colleagues should be commended for that. The financial position across the CCGs of the ICP, Kate will go into more detail. Essentially, we are sticking to plan at the moment, and then there's a couple of more local updates there in the report. But I'm happy to take any questions.
Thank you for that update, Neil. Colleagues, any questions on the content of that report? No. Okay, well, we'll take that as read and understood, and thanks, Neil, for your continued work on the vaccination plans. I know that you contribute quite heavily to that, so thanks for that. Let's move on then to the next item on the agenda, and then we're going to go to Jeanette for the key assurances report, and then the safeguarding report. So key assurances report first, Jeanette.
Thank you very much, Chair. This is an update from the Quality and Patient Safety Committee of activity since the previous governing body. It's now a succinct one-page highlight report which covers quality and safeguarding activity across South Tyneside CCG and its commissioned services. And I think it was well received the last time, so I'm hoping that the format continues to be well received. Obviously, we've, as a governing body and as an organisation, have been very focused around mortality. So there's a quick update there around continuing progress around the actions being taken to be focused around mortality review in our patch. And it highlights a meeting that took place on the 10th of November. The learning is going to be fed into out of hospital forums, and the Trust is engaged in collaborative mortality analysis across North East and North Cumbria through the trusted research environment. We do have representation from the CCG and from primary care within that learning from death collaborative group, which I think is very important. There's also a note around both the Mental Health Trust, Cumbria, Northumberland, Tyne and Wear, the Ambulance Trust, NHS, and South Tyneside and Sunderland Foundation Trust, all showing increased reporting to the national reporting system in the latest released data. One of the important things that I wanted to give an update about, and I'm sure Pat will want to also comment about this, is that we held a learning event from wave 1 of COVID-19 in an informal quality and patient safety committee recently. It was very well attended. It took place on the 7th of October. That had given time for services to reflect and review and take stock, and also identify any key learning. Each service area presented their work and their findings, what their experience had been, and it was a very well received event. There was some particular key learning identified to be taken forward, but in terms of the focus of it, we were very focused on assurance and what we could learn going forward, and I think it was particularly successful around that. In the main, it was felt that systems and processes in place were appropriate and robust. It was a very productive and informative session. I think at the end of it, we all felt that we needed to thank the different services for the hard work that had been in place. I think there was some very enlightening information shared. So, for instance, and I know Louise Lydon's here today, but in terms of the impact on community pharmacies, which I don't think we would necessarily have appreciated had we not have had those updates. So it was an extremely worthwhile undertaking. The key actions to address the learning is being managed through the various working groups to ensure there's no unnecessary gaps. Really important going forward, considering we're now in wave 2. In terms of the last Quality and Patient Safety Committee, we have got there's some key updates there around the support and approach to the primary medical assurance and some improvements to that process. There was an update around care homes, particularly around the current position in terms of the COVID-19 and the actions taken to support providers, but also learning from wave 1 to support both our care homes and our domiciliary care providers, which is extremely important when we're supporting either people to remain in the community or to support people home into the community from hospital. And then there was an update around some research that we were involved in South Tyneside as well as Sunderland called PROACT. This is around raising awareness for the signs, the warning signs of pressure damage, pressure ulcers across health and care settings, but particularly in the community, and training's being delivered aligned with the national programme React to Red campaign. and it was very well received, and that's been evaluated. So that was presented, and it was a very well received research. In terms of patient safety partners, that's already, I won't repeat what's already there. You've had a chance to read that, but just to highlight that this is a difference in approach. It's a consultation. We're expecting something out, probably the final framework early 2021, but this is a change in emphasis towards involving both patients and carers as well as staff and organisations in patient safety, so for them to be involved in their own safety as well as informing organisations how they can improve safety within the organisation. So a completely different approach around that, which is very welcomed. In terms of, I think we've already talked about the patient safety specialist, but we have notified NHS England of our nominated person, who is Kirsty Hesketh, who is our Head of Quality and Patient Safety. And safeguarding, we have appointed into all of the posts that were vacant, so we're now fully staffed across the safeguarding and quality team, which is very welcome. And infection prevention control has been very high on the agenda, as you can imagine, throughout recent months with COVID-19 pandemic. And so there's an update there around some key points. The only point that I would probably draw out is that the ambulance trusts are still awaiting the published guidance around transportation of patients. So at the moment, they aren't able to reduce the 2 metre requirement to 1 metre, which is having an impact on the flow of patients in and out of hospital. And I think the only other thing is, and it's just been published this week, is that CQC have published an infection prevention and control statement outlining its plans for inspection and publication results during winter, which is obviously very important to inspections of care homes, and it identifies the key points that they were looking at when they carried out those focused inspections. I don't think there's anything else I wanted to draw out from that report, so I'm happy to take any questions.
Thanks, Jeanette. Pat?
Thank you, Chair. I think what I'd like to, it's one sheet, but there's an awful lot of information in that sheet, and I hope a lot of assurance to the governing body in that. Because just a couple of things I want to draw out from all of that that's on that sheet is that to give assurance to the governing body that the Quality Safety Committee is continually looking at our assurance mechanisms, systems and processes, and that really was behind that sort of learning from COVID-19 phase 1 session that we had. And I think it would be remiss of me if I didn't take the opportunity to publicly thank everybody who took part in that development session. We learned a lot. We heard about the level of commitment and passion from everybody involved, and a very big thank you to everyone. It was substantial. But nevertheless, the main thrust of that session was to ensure that going forward, that the learning from COVID phase 1 in terms of the practical on the ground issues, that the committee was cited on the right assurance methods, and that we had robust systems in place. And I'm delighted to be able to give the governing body assurance on that. But we will continually monitor that as we go along. The other thing I would just like to add is, and it's mentioned in there, is the research presentation, and the committee were delighted to get that feedback on research. Incredibly important to developing systems and processes and practice in place. But this one in particular was very, very important. Practice has huge impact upon patients going forward. And I think finally, for me, it was good to hear and see evidence of the increased levels of incident reporting to the NRLS, very, very important again in terms of learning and going forward.
Thanks very much, Pat. I'm just looking around the screen for colleagues, Paul, and then maybe Kate.
Thanks,
Paul?
Mark. Jeanette, that was an excellent report. I love the format, so thank you to Jeanette and Kirsty for pulling that together. It's much easier to read in chunks. I'm particularly looking at the infection prevention control bit and the CQC bit on the end, which is very interesting, about inspection publications of how care homes have managed with PPE. Is it possible to bring that back at either one of our governing body meetings or development sessions or another committee, just to see how that goes once it's been done?
Yes, we can either make it a focus of one of the informal quality and patient safety committees, which would then be updated to the governing body if governing body feel that that's appropriate. And Pat, I'm sure will have a view on that, or if you feel there's a more appropriate way for us to bring that through to governing body, we'd be happy to do that.
I'm sure we can do that. We'll take the nuts and bolts of how and where offline and outside the meetings. That's great. Okay. Kate, do you want to make a comment?
Thank you, Matthew. I suppose I was really interested in this information about the patient safety partners. Just sounds like a really interesting initiative, probably a very positive one as well. And wondering whether it means that we would need patient safety partners on our quality committee, or whether it would apply to trusts, I suppose.
So at the moment, at the moment, this is about how organisations work, and it's involving patients and carers. So our role, I think, would be around facilitating that and assurance rather than being actively involved. But it is, I think the important point is this is a completely change of direction and complete change of culture, because this is involving the people who are affected by patient safety in both their own safety and in making recommendations about how patient safety can be improved with providers. Particularly, I suppose the challenge thinking about it would be how we then take that out into the community setting with care homes and domiciliary providers. But the first stage is through mainly acute trusts.
Thanks very much. Tom, I believe you have a comment or question?
Yeah, it was just quickly to say that you will potentially see a link between Jeanette's presentation on the learning events and how the system has coped perhaps with the wave 2 of the pandemic when Matt and I come on to do our presentation. So I just think it's important to know, particularly in the context of excess mortality, that's, deaths that we've seen over and above what we would usually expect to see. So I'll make that reference again when we go through the presentation, but I think it does show that the system's learned a lot in wave 2. So I think it's really positive to acknowledge that.
Thanks very much. Thank you, Jeanette. Can I ask you the blue chunk down the side of the paper on continuing healthcare and the national identification of a potential issue for people finding out that the care entitlement, if you like, that they thought they were going to have is not necessarily what they will have going forward. Now that that's been identified, is there anything that we can do operationally to try to make that process easier?
I think the key thing is the process of going through the assessment. The starting point, of course, should have been at the point that people were discharged with packages of care under the COVID rules, if you like, where there was no assessments, etc. But and funding was just covered through this COVID funding. That an explanation was given at that point that these were exceptional circumstances, and at some point there would be an assessment against national criteria, and should the individual not meet the criteria for NHS continuing healthcare funding, they would then come out of that and either go into local authority supported funding or have to self-fund. So the starting point was that. So we'll find out how well that was done, I suppose, when we start to see issues later on. But the other thing that I think we're doing really well with at the moment is addressing those assessments. So I think, you know, we're working through that backlog at a really good pace, and how that's managed is really important, because involvement of the individual and their families in that whole process, and making sure that they understand what the potential outcomes is, and making sure they understand the decision-making process is really important to mitigate against complaints coming through. So I know there will be some, but I'm hopeful we won't be inundated, because I think we have got a well-managed process. And I saw Matt waving his hand there.
Yeah, I thought you might want to come in on that, Matt.
Just briefly, I mean, to be fair, I think Jeanette just covered it there, which is one of the beauties of the system we've set up around the Joint Commissioning Unit taking responsibility, working across the local authority and the CCG for managing some of this, is that we're able to take out some of the interface issues that people might face in other patches. So actually, we're working really well on the assessments moving forward and the backlog. And I think nationally it's inevitable that there will be a surge in complaints, as Jeanette's paper says, but I think locally we're in a really good position to manage that down and to work with individuals to make sure that we're supporting them as best we can, so we don't get to that point.
Okay, thank you. And I can't see anybody else's hands going up around my screen there, so we will thank you for that that update, Jeanette, and once again echo to the author of that paper, the substantial work that goes into condensing so much activity into one side of A4, but we really do appreciate having it presented in that way. It's very, very useful for governing body members. So thanks for that. We'll note the significant assurance given and the assurance given through the Quality and Patient Safety Committee as well. Let's move on to the next item, which is... Oh,
sorry, Matthew, just comment. I think it's really important feedback, because it's Kirsty who produces that slide, and I know she's worked really hard to give governing bodies something that's meaningful, but also easy to read. And so I will pass on those comments, because I think it's important that she gets that feedback.
Yeah, I think it's been very much appreciated around the screen. So the next item on the agenda is back to you, Jeanette, for the safeguarding report. I can see Sharon and Vicky are with us as well, so maybe I'll leave it to you, Jeanette, to introduce and take that forward.
Absolutely. So Sharon Thompson, who's our designated nurse for safeguarding adults, and Vicky Cotter, I nearly gave her a Sunday name there, Victoria. Vicky Cotter is our designated nurse for safeguarding children, who's recently joined the team. They've joined because obviously they're very immersed in the detail and are happy to answer questions. I'm going to briefly cover the contents. This is an annual report. Governing body receives it every year. It's already been through the Quality and Patient Safety Committee, and it was considered in some detail there, and was agreed there to be formally presented to the governing body for information and approval. The executive summary really outlines all the hard work that the dedicated staff across the system with safeguarding have carried out, all of the safeguarding professionals during 2019 and 20. It sets out the key achievements and for 19 and 20, and also the priorities for 2021, and that's across safeguarding children, children looked after, safeguarding adults, but also the child death overview process. And there's a couple of things that I will mention of note. There's an update around the transition from the local Safeguarding Children's Board arrangements to Safeguarding Children's Partnership Board arrangements, which have now been fully established. And also we have just, although it doesn't cover 2019-20 so much, we had been working towards joint safeguarding arrangements, and next year's report will cover exactly what we've been managed to achieve. The other thing that I would say is that in terms of the statutory responsibilities and local governance arrangements, that they're all covered within in the report. During COVID-19, safeguarding meetings continued. We didn't stand them down. They obviously happened differently. They happened virtually. remotely, but we still continued to hold those meetings. We were particularly, it was particularly important because we were aware of the increased risk around domestic abuse, particularly for people who were under lockdown situation, wouldn't have contact with other people who might have been a protective factor, but also the hidden harm that may have been occurring where there wasn't the normal contact outside of the home for adults and for children. And that's been a constant focus of the two safeguarding forums. In terms of the learning from the child death reviews that happened during 2019-20, there was a few modifiable factors, which means things that might have changed outcomes for the children involved, and most of them actually are related to maternal issues. So, for instance, the mother's weight, so the what's called the BMI, so the body mass index of the woman can have because obviously this covers all deaths, including neonates. So also maternal smoking and alcohol and substance misuse or consumption, but also co-sleeping. So they were the main things that were picked up in terms of themes, but we do have very low numbers, and I think it's important to point that out. In terms of the priorities that they obviously agreed as a system and they outlined. And the only other thing I was going to mention was we've obviously been working very closely with the Safeguarding Integrated Partnership team, and there's an evaluation of that new way of working which is awaited, which I think it's really important, because that was a service that was looking to support and work with in certain individuals who had previously been very difficult to engage, and so I'm really keen to see what the outcome of that piece of work has been, and I don't think there's anything else I would add, but we've got both Sharon and Vicky here if there's any detailed questions that anybody would like to ask.
Thanks, Jeanette. Colleagues, any questions on the detail or of the report for either Jeanette or either of the experts from the team who are waiting in the wings? Yeah. It's been through a number of committees. Pat, I think your hand's there, yeah.
Sorry, Matthew, you just anticipated what I was going to say. It was discussed thoroughly at the Quality Patient Safety Committee.
Yes, and it's something that we make sure gets through several rounds of discussion. I think it's not the first time I've seen this report and had the opportunity to discuss it either. So thanks, Jeanette, for bringing it here. You want to make a final comment? Yeah, a final comment. Just I would like to just thank the Safeguarding team across both the local authority and, of course, our own team, because they have worked very hard during these very difficult circumstances to ensure that they are focused on both safety and safeguarding, and to be very available and supportive of the whole system to make sure that we are at the very front of supporting people wherever possible. Indeed, and I think there's lots of nods around there thanking the team, so I can see Sharon and Vicky on here, so thank you very much to yourselves and to other members of the team for your work throughout what has been throughout this year, but also throughout what's been a very difficult time for safeguarding through the pandemic. So that's been another team working in a very different way. So yes, thanks for all of that hard work.
Thank you, Jeanette.
I will echo one of and perhaps draw out a little further, one of the things that Jeanette mentioned about the child death work there, and the links to maternal health, maternal wider health in terms of weight, alcohol, and smoking particularly, and look at some of the work that's been done over the years under the auspices of the Health and Wellbeing Board, with the CCG and the Council working together to really reduce our maternal smoking rates, and as this really demonstrates why that work is important. This is about saving lives of children at the end of the day, and I think that just gives a nice sort of rounded join up to some of the joint work that we do in South Tyneside and the way that we work together. I'll give Tom the opportunity if he wants to come in on that, but you don't have to, Tom, if you don't want to.
I think I just echo that, and I think particularly the establishment of the midwife-led baby unit and its connections now to the broader community has been really strong over the last, despite the difficult context, but working really closely with our health visitors, our community services, and our children's centres. And I think that's been at a very operational level. I've seen that change already, which I think has been really good to see, and shifting the focus away from the medical aspects of having a baby to more of the holistic aspects of having a baby, which I think is really positive to see.
I know we strayed away from safeguarding there. Sharon, shall I leave you the final word?
Just to raise from an adult perspective in terms of priorities going forward next year, I'm sure the governing body is all aware of the changes of legislation with regard to the Mental Capacity Act and the deprivation of liberty safeguards. This is a piece of legislation that will impact on the learning disability work stream, our CHC work stream, and all our vulnerable people who may lack capacity, who we commission care for. So it's just really important that priority links across our mental health and our CHC and our safeguarding work streams next year with our partners as well. So just to highlight that from an adult perspective is something that we're aware of going forward. Thank you.
Thanks very much, Sharon. So we'll, as a committee, note the contents of the report, the substantial assurance that it brings, and agree to adopt the report as requested. Okay, and we'll move on then to the next item on the agenda. Say goodbye to Sharon and to Vicky, I assume, at this point. So we'll move on. The next item is the partnership section. We've rechristened this coronavirus and partnership because we're aware that the partnership has been doing a vast amount in the response to the pandemic, and we'll leave the sort of the more traditional partnership reports for another day. And Tom and Matt, I think you're going to do a joint verbal update on this item.
Yeah, let's perhaps leave Tom to open, and I'll follow if that's all right.
Okay, no problem. Yeah, and Matthew, I'm going to share a few slides if that's okay. Obviously, I hold these back from the papers just because we want the latest picture. So I'll bring them up. Can you see that, Matt? You're on my screen. Yeah, brilliant. Thank you. So yeah, just wanted to kind of share the latest picture in terms of COVID-19 in South Tyneside, our local response, and indeed our regional response. I think the way that the 7 local authority areas and associated partners have worked together during the second wave of the pandemic in particular has been a real high point for me. I think the collaborative work has been really strong, and I'll close the presentation with the 5 key strands of work that we're working together on at this point in time. But I just wanted to start by saying that I think that strength in collaboration has been a real positive during this second wave, and it's helped us deal with what has been again a very challenging situation that I know many of you have been working on at a strategic but also at an operational level as well, as Matthew joins us from his surgery. So I know how hard this has been for everyone, and I just want to thank everyone for their work on it so far. Obviously, it's quite a big day today. We get to find out what tier the Northeast is likely to be put into when the national lockdown, or lockdown 2.0 as it's been referred to, comes to an end on the 2nd of December. So we had early local leaders meetings this morning in anticipation of a meeting later on today with ministers about what our local situation will be. So we're expecting it to be out in the public domain today. I just want to reiterate that at that kind of regional level, we agreed some priorities that have dovetailed with our own local priorities as a system, which is that we've been very clear that we want to try and protect the most vulnerable from harms associated with COVID-19. We want to prioritise the education and welfare of our children and young people, and we also want to try and support local business and the economic recovery of the region as well. I think that last point in particular is to recognise that although there are immediate impacts of COVID-19 on our populations in terms of health and well-being, actually the bigger impacts of COVID-19 are going to be broader public health impacts that are associated with loss of income and loss of work altogether. So we need to recognise that if we don't support our local economy, then we perhaps face bigger challenges down the line in terms of health and well-being and the outcomes for our population. So I just wanted to reiterate that at the beginning. Just in terms of more of the specifics are the local case rates in South Tyneside. I'm just going to move Matt out of the way so I can see my screen. So this chart here shows the rolling 7-day total of cases per 100,000 population across the northeast and England, and then it also shows it specifically for South Tyneside. So South Tyneside's this blue line here, and the northeast red line. The LA7 is the orange line, and the England rates can be seen as this purpley coloured line here. Last time we came together as a governing body was back in September, so around about this point here. So you can see we'd been dealing with a challenging rise in the number of cases in the borough. That shortly after the governing body meeting started to top out. We'd just seen the introduction of northeast restrictions that we'd asked for as a local authority 7. We'd been proactive and going to government saying we think we need to do these things to help control the local infection rates. That was ahead of the national tiering and moving us officially into tier 2, which came in mid-October. And we saw how much of an impact that started to have. The rolling 7-day rate in South Tyneside topped out around about the beginning of October and actually started to come down very steadily during October to this point here, which takes us to roughly around about half term, and also when it became apparent that there were going to be national restrictions brought in. That in itself seems to have caused another big surge in cases, particularly in South Tyneside, but also across the rest of the northeast. We're now at a point now where we're starting to see the case numbers drop again, thankfully. In the last 7 days, we had 528 cases. In the 7 days prior to that, we had 650. So you can start to see them coming down quite consistently now. But it does show that even with all the interventions we've been putting in place, particularly as we move to a heavier, harsher winter, it has been challenging to control the number of infections in the population. But it's pleasing to see that starting to come down. But this decline should feed into the thinking around what tier the northeast comes out in today. But I strongly suspect we're moving towards the highest level of restrictions. But obviously, I can't predict exactly where we will come out. But I think there's a recognition that actually the population is starting to struggle with the level of restrictions we've got. But we did see really good compliance prior to the national lockdown. I think if we start to win back some of the hearts and minds and recognise that actually just by doing the simple things we are controlling the virus, then I think that would be a real positive place for us to get back into. I think that local determination and local control of our measures has been a strength of our work, particularly during October. And I think if we start to move back to a greater sense of we're in it together for the northeast, then actually these numbers start to come under a great level of control again. I'll just move on the slides. Actually, I'll not spend too much time on this. This just changes it from looking at a 7-day rolling rate to looking at actually the daily cases. So the dark blue line are the pillar 1 cases, that's community testing, and the light blue line is Pillar 1 testing, which tends to be NHS and Public Health England testing. So predominantly in terms of hospitals and care homes, the light blue line shows you what's been happening, and the dark blue line tends to be more what's happening in communities. In terms of the situations we've been managing, it has largely been widespread community transmission. We've not necessarily seen big outbreaks. I feel like I'm broke a record in saying that, but we've not necessarily had big outbreaks in South Tyneside that we've seen in perhaps some other parts of the region. It has been that rising tide of cases. We've seen occasional clusters associated with some workplaces. We've obviously had to deal with a lot of activity in care homes, but that is predominantly during wave 2 has been sporadic staff cases, maybe 2 or 3 staff members that have tested positive, that not necessarily the care home itself, the source of the outbreak, but obviously they're picking up in the wider community. And of course, we've seen a lot of activity in schools, but again, the activity in schools has predominantly been in teaching staff rather than pupils. But at this point in time, we've got 8 cases in special schools, we've got 24 cases in primary schools and 27 cases in secondary schools. So we still see relatively high numbers in schools, but it is being managed well, and the schools are doing a tremendous job of keeping on top of the bubble closures and making sure that they're doing the associated contact tracing. So they've handled it excellently, to the point where actually, although year groups and bubbles have occasionally had to be sent home, we've not really seen large-scale school closures, again, that we've seen in other parts of the country or indeed in the northeast. There's only been the occasional school that's actually had to fully close its doors. Just back to the messages I was giving before in terms of where we're at this point in time. South Tyneside sits relative to other areas in the northeast at roughly the same sort of level. We are slightly higher at the moment, but that is likely to be as a result of one care home situation that we have been managing, which has pushed our numbers up slightly. But we are still seeing overall that decline that I mentioned before. Just in terms of age groups, and this goes back to some of what I was saying before in terms of how well we've managed to control things in care homes and in schools, is that our lowest rates of COVID-19 per age group have been in the 0 to 14 population. So you can see this orange line here, and then in the over 65 population, you can see here. The community transmission has predominantly been in basically 15 to 50-year-olds. And they're obviously the age of the population that's out there, going to work, going shopping, and socializing prior to lockdown obviously was one element that played into it, which we could see in perhaps the 15 to 34-year-olds before the national lockdown hit. But predominantly we've been able to protect the over 65 population, although we've seen that recent creeping up in cases. Again, we're thankfully starting to see that come down. Just a quick nod to testing. It's quite a complicated chart, so I'll just point you towards the bits I wanted to show you. This kind of grey blue bar here, the 2 parts of it in total show the rate of testing in South Tyneside. So this is how many tests we've been doing in Pillar 1 and Pillar 2 over the last 2 weeks. And again, it's just to reiterate that our testing rates in the borough have compared well to the rest of the northeast throughout the pandemic, which is indeed in South Tyneside probably one of the higher areas on the left-hand side here. But in the recent weeks, we've also been testing at relatively high levels as well. We've obviously had mobile testing units up and running in South Tyneside during September, October at Littlehaven and Temple Park. We're now only utilising the Temple Park site because we've mobilised a testing centre at the Old Jarrow Library, and we are in the process of mobilising one in Tutorreed that should be up and running at the beginning of December. So we're continually adding to testing capacity, as well as the testing regimes that we've got in hospitals, with NHS staff and in care homes as well. Just in terms of outcomes, this linked back to the point I made when Jeanette presented her report as well. It's looking at the rate of excess mortality in South Tyneside. So this is how many more deaths we're seeing compared to what we would usually expect to see. So these grey and red bars here compare the number of deaths that we're seeing in 2020 during the weeks numbered along the bottom here, compared to what we would usually expect to see and that's the average of 2014 to 2018. So that's these little, if you can see it here, these little green bars highlight the levels of mortality that we would usually expect to see for this time of year. Obviously, during one we had this rise in extra deaths compared to what we would usually expect to see, and much of that was associated with COVID-19. During wave 2, although we've started to see deaths in individuals who have had a positive test for COVID-19, we've not necessarily seen the same rise in excess deaths that we saw in wave 1. So I think that's a testament to the way that we've adapted our response, to the way that we've been able to manage COVID-19, particularly in the care sector and obviously in the acute sector as well. And it just demonstrates that we're seeing a very different picture during wave 2 and actually managing to protect those who are more susceptible to COVID-19 more. I think it is important to say that there is potentially an element of the first wave of COVID-19 may have brought some people who are near to the end of life, brought their date of death forward slightly. So it could well be that we've essentially brought forward the end of life for some individuals in the borough, which we're therefore not seeing during this second wave. That's one theory, but what we need to look at is these data over time, and that's why I continue to bring this back to you, because it's the longer we look at this, the more clear it is how much excess mortality we've seen as a result of COVID-19. Just want to finish then in terms of, I mentioned before that the strength in partnership working has been a real positive during particularly the second wave of the virus. As a local authority 7, we've identified 5 key priorities that we're working on jointly together. That's making sure that we continue to try and take our communities with us, recognise that there's a certain amount of COVID fatigue and people not necessarily adhering to the restrictions and guidance that is being given. We think it's therefore really important that we understand how communities feel and we understand what their thinking is at any point in time and adapt our communications and our approaches accordingly. So we've been doing some insight work with a social marketing company called Drummond, and they've developed a local campaign which is starting to roll out at the beginning of December. And that's going to be more bespoke communications for our local populations and different types of comms approaches that building on direct insights from our local communities in terms of how they're feeling and what sort of messages they'll respond to. We're pushing hard to get more localized, regionally coordinated test and trace. You're aware that there's the national NHS test and trace program. We think it would be far more effective if it was regionalized and brought under more local control, and that would be our proposal is to bring it under the control of the Northeast COVID hub that's being led by Newcastle Hospitals. We haven't had a firm yes or no to our proposal on that at this point in time, but we continue to push because we think it would allow the test and trace program to connect much more effectively with our local response, and that would improve the adherence of the population to the isolation as well as going to get a test. There's no point in getting tested if people don't do the associated isolation and contact tracing. So it's really important that we improve that element of the test and trace arrangement. You'll be aware through the media, and particularly the national rollout of frequent rapid lateral flow testing and some of the pilot work that's been happening in Liverpool. We're working together on terms of our proposals of how we might use the lateral flow testing in more of a targeted way to help protect those most susceptible to COVID-19. We'd originally proposed to do work with care homes and care home staff and to support care home visiting, but that's now been overtaken by a national programme. So we're reviewing how we might use this, particularly to target different, more at-risk populations to improve the rate of testing in those communities. We'll continue to collaborate on how we work with more vulnerable individuals. This is building on the lessons learned from the shielding hub arrangements during wave 1 and looking at more community support approaches. We've stepped up a community support approach in South Tyneside for wave 2 that builds on the package that we had in place for wave 1 to support shielding, and that's to help with shopping, medicines, general well-being, and helping to reduce social isolation. So many areas of the Northeast have got those types of arrangements in place now, and in South Tyneside we're operating that out of the library in South Shields, out of the Word. And then finally, Neil's already touched on this, but the preparation and implementation of the vaccine programme, again, that's been coordinated at a regional level, but there's a strong emphasis on local delivery as well. And I know the CCG in particular have been working very closely with the primary care networks to establish the vaccination centres that we'll be establishing to make sure that we get to the most vulnerable populations first as part of the vaccine programme, and make sure that obviously the NHS is ready to start vaccinating from the beginning of December. So there's been a lot of work in the background on mobilising all that, and big thanks to all those who have been involved in setting it up. And yeah, I think it's just important to note here that we have had a really good flu programme this year, and there's a lot of lessons to be learnt from how you deliver vaccinations at scale and how you improve the levels of uptake. So we're working to use our local infrastructure around flu delivery to support the vaccination programme for COVID-19. So building on what we've already been doing so far is a core part of this. So I'm just going to stop there and see if Matt wants to add anything, and then take any questions.
Thanks, Tom. I think that was really comprehensive. So just a couple of quick points. Firstly, I think we should note that the partners around South Tyneside worked incredibly well together the last 9 months, exhaustively. But I did want to just note the leadership from the Director of Public Health and Tom and his team, which has been fantastic over the last, over this COVID period. So thank you for that, Tom. Puts us in a good place. And just the second point I think to note, and I'll touch on this in performance, is that although the COVID numbers have come down, they still remain at quite a high rate. And we see that in terms of the challenges that our acute hospital colleagues are facing as well. So we do have a significant number of COVID positive inpatients in both South Tyneside and Sunderland hospitals, which replicates the rest of the region, and a number of patients in intensive care. And so as we enter the winter period, it really is going to be a tough and challenging time for our hospital sector, as well as for primary care, community services, community pharmacy. But certainly we've got some real challenges in how we make sure we support the acute hospital sector to deal with our sickest patients.
Thanks, Matt, and thanks, Tom, for a lot of detail there on that. I'm aware we could probably talk about all of this for the rest of the day if we wanted to, but can I ask anybody members just to restrict themselves to items of assurance rather than the detail that we could get into. So, Pat.
Thank you, Chair. Great report. Well done to everybody for all of the work that's doing. I guess one of the things that I'm looking forward to is the community campaigns that you talked about, and I'm looking for some assurance that we're not going to be solely reliant on digital communications, that we will take into account those who don't have access to IT.
Tom?
Yeah, absolutely, Pat. It's a really good point. I think Drummond are a well-established marketing company, and they recognise the different modes of communication that will land best with different population groups. So they're segmenting the population and making sure that we're delivering the messages accordingly to different priority groups. So, yeah.
Thank you. Jeanette?
Yeah, thank you. So I suppose as well, it's just a little assurance that those messages, and I know it's very difficult, but if they're going to start in December, is it going to particularly focus on around caution around that period of respite over Christmas, when we're just seeing numbers coming down after being at like quite a high spike? Because obviously the concern is that a couple of weeks into January we're going to be way back up with another spike.
Tom?
Yeah, I mean, I just totally agree with that, Jeanette. I think I know it's been really challenging throughout the year so far, but I guess we don't want to throw it all away by suddenly going a bit wild before Christmas, do we? I think it's seeing us through the Christmas period, and I know it's an extremely challenging time of year, particularly if people want to see loved ones and all the rest of it. But I think there's the population's responded so well so far, and I think that we want to be cautious around throwing away the good work, and actually meaning that we're having to deal with this for a lot longer into 2021 as well. I think we're seeing the rates come down. If we can continue to suppress those numbers, we're all the better for it as a population, and we also protect the most vulnerable and make sure that the NHS can function over the winter period, because like Matt says, there is a lot of pressure in the hospital sector in particular, and we need to make sure that services for everyone continue to function during winter, not just COVID services.
Thanks very much. Thanks for the report, Tom, and for the leadership throughout the pandemic from yourself, for the borough as well. Oh, that's my fire alarm going off. Great timing. I think it's just a test. It's okay. It does that every week. We'll accept the verbal reports. Thanks once again, and move on to the next item on the agenda, which I think is Matt and the performance reports.
Yeah, so I'm just going to very quickly, if I can, try and share this slide deck, although it's not appeared on my screen. So bear with me 2 seconds. Matthew, can you see that? Yeah. I'll run through this very quickly, just conscious of time. I think it's probably worth starting by saying to members, we've got a stripped back performance report here, as we have done through the COVID period, but from next meeting in January, we intend to start bringing the broader data that we have around more community and preventative measures, so things like dementia diagnosis rates and so on. So at the minute, I'm just focusing on the hospital performance key indicators. So hopefully you can see I'm on slide 2, the A&E slide. So I won't dwell on this too much, but obviously noting last winter we had extremely challenging performance. The red line is our performance for last year, and the green line being the 95% indicator. What we've seen during the COVID period is actually fewer A&E attendances, and so our performance has recovered back to a sort of more normal level. But I do need to urge caution for governing body members. I think what we can see now is that the increasing pressure of COVID inpatients and the usual kind of winter demands are creating some real challenges for our hospital system. I think it is unlikely we're going to be able to maintain this level of performance in terms of how long patients are spending A&E into the winter. Clearly, we've got one of the highest performing systems in the region as it stands, and we want to maintain that. But I do think it's important that members are aware that it's going to be challenging to maintain that into the winter. Just briefly, this is the elective referral to treatment, RTT. So this is the proportion of patients waiting for 18 weeks or fewer for their elective treatment. What you can see clearly when we went into the COVID period in March and April, we had to stand down a significant number of activity, which the consequence of which has been that a number of patients have been waiting longer. So we've been able to deal with fewer patients within the 18 weeks, but we are now seeing good recovery. And as Neil touched upon in his accountable officer report, actually our closest providers, particularly South Tyneside Sunderland Foundation Trust, have really started to get online with the national trajectories and starting to get back towards normal levels. So we're really seeing some encouraging activity around this. The challenge will be maintaining this through the winter when we've got the normal number of emergency patients and COVID inpatients to deal with. So again, the winter will be challenging for recovery of this indicator. In terms of diagnostics, so our aim is that no more than 1% of people should wait longer than 6 weeks for a diagnostic test, so an ultrasound, endoscopy and so forth. And you can see in the 3 years prior to this year, we've been extremely good at achieving that indicator locally. Clearly, when we had to stop activity during the early part of the COVID period in March and April, that's had a big impact, and therefore far more patients waiting longer for their diagnostics. Now we are getting back on top of that, but there are some real challenges. So particularly around endoscopy provision, that remains a challenge. We're getting back on top of it, but it is going to take some time before we're able to reduce the backlog to the levels that we might have seen a year ago. This is cancer, so the proportion of patients seen within 2 weeks of an urgent GP referral. Unfortunately, again, during the COVID period, we saw that drop down to about 70%. We are seeing recovery on this indicator now, but I think there are two kind of key pressure areas for us. So breast services remain a pressure area for the region, although actually the median time with which people are waiting is only just over the 2-week period, but that is a pressure area against this 2-week indicator. And for South Tyneside particularly, the skin service at Newcastle Hospitals has been under a significant amount of pressure. So the implementation of a new teledermatology pathway imminently should help with that, but it will take some time to recover. And this is the number of patients, proportion of patients treated within 2 months of an urgent GP referral for cancer. You can see, although there have been some dips, actually that has returned back towards where we'd normally expect. I think it is worth pointing out that there are around about 30 patients a month who come under this indicator. So quite small variations in our ability to treat people in time has quite an impact on this indicator. I think I'll probably stop there, Matthew, just conscious of time, and people may have questions they want to ask.
I wonder if it's worth taking the actual, as you've mentioned, a lot of performance is impacted upon by winter and going forward. So I wonder if it's worth taking that presentation next and then asking questions on both together. Do you think that would be sensible?
Yeah, I'm so happy to do that. I know Neil had his hand up there, but
it was just a quick point really on the breast diagnostics, just to give governing body assurance that I am taking the work forward at an ICS level. There is a collaboration of all the foundation trusts being established across the ICS, and it is top of their work plan to sort out. There is local improvement, but still, you know, meeting that 2-week standard is an absolute priority, and it will a regional solution will be needed. So it's just to give governing body assurance it's high on the work plan, and hopefully we'll start to see some movement on that soon.
Thanks, Neil. So I think we'll move on to the next presentation, Matt, from yourself, and then we'll take some questions as a furthering from that at the end, particularly around the acute A&E performance and elective RTT and so on, because they are all, as you say, wound up together with winter. Is there a second slide deck for us?
There is, just 2 seconds. Hopefully you can see that says system resilience and winter planning, great. And the slide template is a little different, reflecting the fact that actually we do a lot of the planning across the North East and North Cumbria footprint. So our patients live in South Tyneside but use many of the hospitals and systems around us. So South Tyneside, Sunderland, Newcastle, Gateshead. It's really important we work with our partners, hence the slightly different footer. Conscious of time, I'm going to go through quite quickly, I think, Matthew, so I might suggest that people ask the questions on the things they're interested in. So forgive me if I'm skipping through things. So really, this is just to reflect. This is a summary slide to reflect the fact that we plan for winter from each summer, and in fact, often from each spring. There's a huge amount of thought that goes into it, but this year, the COVID pandemic obviously brings a different focus and a slightly different approach to our planning. So I'm going to talk a little bit about last year, some of the schemes and things we put in place to help manage winter, and then talk about our approach this year. So these are some of the key interventions that we've put in place for 2019-20 with a particular focus on discharge. Now, just to take a step back for a second, we talk about A&E performance, but the key driver of A&E performance is the amount of bed capacity there is in a hospital system. And the amount of bed capacity in a hospital system is driven by our ability to support people, support patients, to be discharged to an appropriate place for them in a really timely and safe manner. Hence, we focus on these kind of things. So discharge, transport, social workers and brokerage for care packages over the weekend to make sure that Saturdays and Sundays we can support people to be discharged to an appropriate place in the same ways through the week. Extra pharmacy support, home from hospital, which is age concern, we're able to support with things like specific equipment or changes in the house that need to be made. Extended access to diagnostics and therapy teams. So some of the things that we put in place last year. And I won't go too much over it, but we can see really clearly that some of these things had quite a big impact, particularly when I talk about the additional extended access into general practice services, which we think had a big impact on the system. A quick note though, when we're reviewing what does and doesn't work, it's really important to focus on the things that we think didn't have the same impact. So what we were really clear on is that actually those schemes where it needed lots of new staff to be recruited, where there were multi-agency provision arrangements, or where actually we're reliant on 1 or 2 people. Those were the ones that were most challenging to actually get in place for the winter, to maintain through the winter. And the final point on that slide is, unfortunately, because we put a large number of schemes in place each year, it is difficult to be able to be really crystal clear about the attribution of which ones work in which way. So we look at a range of services and measures together. This is some of the consequences of the pandemic that I won't dwell on. In terms of thinking about the year ahead, so 2021, there's 3 key categories that we've got there. So things that are trying to support people to stay safe, well, and independent at home, attendance and admission avoidance. So making sure we've got good rollout of flu, really good support from mental health services, community teams. Again, focusing on the discharge process, so what we call Discharge To Assess, which I'll touch on in a second, and then maintaining flow through the hospital system. So the safer bundle, which is a specific bundle of things that the hospital's team should do operationally each day to make sure that the flow through the system works really well. So Discharge To Assess, I think this reflects the fact that, and Jeanette may wish to comment on this, that in general terms, when people who are a little older are being discharged in hospital, it's not usually a good place to assess their long-term needs. So what we try to do is support people into a more homely environment where we can make a better assessment of what their ongoing needs and support would be and help them into a more appropriate longer-term residence. The flu campaign we've talked about, so this year there's a really good flu board in place, and we can see on every measure actually that we're achieving greater levels of vaccination than we have done in previous years at earlier points. That's really encouraging. What we don't want is to have people who have lots of symptoms that could be potentially COVID, could be potentially flu, arriving into A&E departments over the winter. So flu is a particularly important priority for us. And I think it's worth saying Dave Julian's taken a real strong lead on this, one of our clinical directors this year, binding the system together across PCNs, across community pharmacy and across all our partners. I've touched on extended access. Certainly this is about having access to our GP practices in the evenings and particularly weekends, and colleagues in South Tyneside Sunderland Foundation Trust are really clear that actually the impact on that this winter already has been a reduction in some of the patients who are coming through into the hospital system over the weekend, which is really encouraging. And transport is a key issue, and it's a key issue across the region, but the challenges, of course, of having social distancing and so on mean that we can use transport vehicles for fewer patients. So each vehicle can take fewer patients than it might have done a year ago. So actually that's meant we've needed to put in some extra capacity and look at how we make sure we get a really slick process so that we're making best use of all the capacity we have. And we've put in place a specific piece of transport around emergency medication, which should be helping a significant number of patients. People might want to ask about Surge. So we have any delivery board that sits across South Tyneside and Sunderland, which I'm currently chairing, and in each patch, one in South Tyneside, one in Sunderland, we have a Surge arrangement. They have slightly different names. That is representatives from all the agencies who come together on a daily basis to make sure we work through any issues that are arising, supporting every resident and patient to be in the most appropriate setting for them. And we've also put in place a GP support line for community teams and care homes. So a GP over the weekend who those teams have got quick access to, and that's really been able to support a significant number of people to stay at home when otherwise they might have had to go into hospital. I won't touch on that. Just finally, some of the risks. So we've talked about the flu programme, and what we must do is not see drop off in the flu uptake as we get the COVID vaccine up and running. So we really need to make sure we maintain that, and I think the team's done a really good job of that. I think the only other issue I'll pick up is the new Help to Live at Home model. So this is about domiciliary care. One of the real challenges for us in South Tyneside is having the domiciliary, that's the home care capacity that we need on a timely basis. I think the council and our joint commission unit are doing a really good job at addressing that, but it still remains a pressure. And the final issue, I think I perhaps won't touch on these because I think the risks are more significant that I covered in the previous slide. Apologies if that's a whistle-stop tour, but hopefully I've kind of covered some of the key points for everybody.
I think we'd have the slides in advance to digest anyway, Matt. So so thanks for putting out some of the key things and expanding on those. Any comments or questions from colleagues for Matt there? Louise?
It was just to give the governing body some reassurance. The emergency medicine scheme, which was previously set up to help with palliative care medication, it's now been extended for all emergency medicines. It's providing pharmaceutical cover 24/7, which is a really high level of provision compared to a lot of other areas. So it's a really good service in South Tyneside. It's working seamlessly. And the use of electronic transfer of prescriptions is helping with that. So the prescriptions arriving at the pharmacy electronically, and the pharmacy's then delivering out the medication through the evening. And there's no problems at all with the service. It's working really well.
Good to hear that. Any other questions or comments from colleagues around the table? No. In that case, Matt, it certainly looks like there's as usual, an awful lot of work gone into planning for winter, and an awful lot of really joined up work, thinking outside the box, innovative type work that we come to expect as the normal in South Tyneside. But I reflect on the winter plans that we have in place now compared with the winter plans that we had in place 7 or 8 years ago when CCGs first took on that. There's a whole world of difference there. We really have moved on, and I'm really hopeful that we're making a much realer difference to patients and to our systems in the winters. So thanks for all of that work that's gone into that. I will take the opportunity then to move us on to the next item on the agenda, just as my screen disappears. So that's Kate, I think, and the financial monitoring report, and then budget proposal. So over to you, Kate.
Thanks, Matthew. So yes, I'll refer you to enclosure 6, the finance report in the usual format. There's nothing really to update in terms of the financial framework. I think I've updated the government body in previous meetings around the financial framework, and nothing has changed since previous months. So in terms of planning, we're still looking at a £9 million deficit for the ICP, sitting with South Tyneside and Sunderland Foundation Trust, linked to the non-recovery of non-NHS income. We have a £2.4 million reserve sitting of top-up funding, if you like, that has not been allocated, and nobody has called on that yet. And we have a monthly ICP review of each organisation's positions, just to understand any pressures or flexibilities in the system. A couple of bits of additional funding have been announced in the last week. One is an additional £150 million for primary care, and that's coming down to the ICS level. I think it's £9 million. I think for CCG about £460,000. That's linked to a number of must-dos, if you like, one of which is around the recovery of activity levels in primary care and general practice, and the delivery of pulse oximetry and virtual ward arrangements. Apologies if you just heard my phone buzz. And then there's also been an additional £15 million for mental health discharge, which I think will come down at about £3 million for the ICS, and that has yet to be distributed. So they're not reflected in the report yet. It was just to update governing body members that they would be coming soon. In terms of the financial position at month 7, a deficit of £750,000 is forecast relating to the hospital discharge scheme, which is continuing on a retrospective claim basis, so it shouldn't be an issue for us. And then there is also the assumption that the month 6 claim, the retrospective claim that went in for COVID costs of 1.8 million, will be reimbursed by NHS England. They are crawling over the month 6 claim with a fine-tooth comb, it's safe to say, because I suspect some organisations have chucked the kitchen sink at it to try and claim some costs at month 6. Obviously, we wouldn't do that in South Tyneside. But we are just waiting for them to clear that and release that funding. Other than that, I didn't really want to flag anything else up on the finance report. Just open to questions.
Thanks very much. The point at which I usually on to see if there's anything that he wants to add as chair of audit. committee. Neil was waving his hand as well. So Neil first, and maybe John.
It's just really to say, I think it's fair to say that throughout this year and through the additional costs of COVID, we have money hasn't been a big blocker in our response to COVID, which is very good, which is excellent, and that's what we were promised by the government, and I think it hasn't been a huge block to us delivering the best service for local residents. What I am just going to do an early flag is the concern about next year. And Kate will probably bring it up in the budget setting paper maybe, but there's still a lot of uncertainty about next year. There's talk about a new financial framework. I'm just putting a line in the sand in that there is still a lot of unknown for next year. But as soon as we have that detail, we will obviously bring that forward. Welcome news on capital spend from the Chancellor, which I think will be very well received. But again, as I say, there's a talk about cost of care for FTs and a blended approach to moving away from PBR, but we don't do that anyway because we've got block arrangements. But it's just to raise that concern for next year. That's all.
Thanks, Neil. John.
Yeah, I'm always quite sort of reassured by the consistency in Kate's presentations and the information that she presents, so it doesn't really give me any concerns. I support some of Neil's comments about finance hasn't been the a block or in any way on COVID. It's been other system issues, but Kate's message is always reassuring and consistent, and I take a lot of reassurance from that.
Great, thanks very much. So I can't see anybody else desperate to contribute. If we can receive, note, and approve the report then, and move on to the next item on the agenda, which is Kate again. And again, and really unprecedented to be in November and still talking about draft budget proposals for the current year, let alone this is the point where it usually starts to think about draft budget proposals for the next year. But over to you, Kate, for that.
Yeah. Absolutely. I suppose it was just recognition that we hadn't brought a finalised budget to the governing body for sign off. We brought draft budgets in March that were linked to our planning processes, but then of course everything, all bets were off, and we got a new financial framework from April through to September, and then now from October through to March. So these budgets are really just to reflect the allocations that we've been given, the determination by NHS England of where our expenditure will lie. And we will monitor from this point onwards based on this budget if governing body is happy to do so.
Colleagues, we've had various iterations of these types of discussions, both formally and informally before, so I presume we're all happy to give the approval that Kate gives.
Thank you.
Nobody saying otherwise. Great. Okay, and in that case, we'll move on. Next item on the agenda, which I think is the assurance framework, and I'll hand over to Keith Haynes for that paper. Keith.
Thanks, Matthew. So this again is the updated governing body assurance framework. We've developed it as in the usual way by holding a sort of 2-3 hour workshop with the key authors, essentially to update their elements and their aspects of the board assurance framework. I think probably just worth calling out 2 or 3 things. We've amended a couple of scores in relation to COVID related items, and we've amended them slightly downwards in actual fact. So risk 2348, which refers to recovery of services after COVID in the context of the phase 3 recovery letter and the planning that's going on and the progress that's being made. In discussion with Matt, we took the view that should be downgraded from 20 to 12, and similarly in discussion with Kate in relation to risk 1909, we've downrated that particular element of risk within the assurance framework as well. And I think I'd just make the other comment that we made, I think last time we looked at the assurance framework, that the assurance has continued to work actually, and the frameworks continue to operate in relation to the arrangements that the CCG have had in place during COVID. So I think that largely has obviously been very encouraging despite all the operational and other pressures that the system has actually seen. I also, interesting, we had a conversation earlier in the week with John Whitehouse about the assurance framework as a piece of sort of ongoing work that the audit committee also are reviewing on a regular basis within the CCG as well. We're very happy to take any questions, any issues from any members of the governing body.
Neil?
Yeah, it's. I mean, happy to go along. I'm just wondering whether or not it might be a little premature to downgrade that risk of hospital delivery services. It's again, it's open to interpretation, but I do wonder if it's premature. We're heading into winter. I know that cases are coming down now, thankfully. January, as we heard from Tom, there may well be some increasing cases. I'm not sure about downgrading that risk, to be honest. But I'm happy to go along with governing body's view on that.
I guess my personal thoughts on that it was a very, very significant risk. There's been a lot put in to mitigate. It still yet may be that those mitigations don't provide for everything that we expect them to. But equally, I think it behoves us all to be keeping a very close eye on that, and should we see that happening, upgrade the risk again and look to further mitigations. I mean, I think it gives us that flexibility, that the framework that we've got. Would you feel, Matt, that that's appropriate, and Keith?
I mean, I think it's a judgment call, isn't it? So for me, the judgment was on the basis of when we started, the risk was extremely high with no mitigation really, and so actually when you look at how much we've recovered since March, which is when we set that initial level, I think we're in a better position, albeit it still remains a risk. So I think you're right, Neil, it still remains I think just about the highest risk on the register.
I guess it's a point in time, isn't it? You're right. It's a point in time, and then come next governing body meeting, things may well have moved on, and then we would have to review.
The main point is it's not going to come off the assurance framework at this stage. So you've still got sight of it, I think, as a governing body, and I think that's the important point, I guess.
Yeah. Can I just make one other point on overall CCG assurance, just for the attention of governing body members? The assurance ratings for the year 1920 were published yesterday on the NHS website. I'm pleased to say South Tyneside were rated as good, with a green star for their engagement activities. So it's just really to congratulate. I mean, nothing to do with me, obviously it was before my time, it's the last year, so well done all you guys. But that's very good news, and obviously we'll plan some communication out. It only came in lunchtime, just after lunchtime yesterday.
May I just comment on that? I think it's just reflecting the work of the team around particularly the patient community engagement indicator. So I think Paul Cuskin, who is not on my screen at the minute, but Paul, working really closely with Helen Ruffle in particular, have done a huge amount of work on that. So I do want to express, I think, thanks to those two in particular.
Yes, and I will echo my thanks to the team for all the work that went into getting that good rating on the national league tables, though they're not league tables, though that's what everybody seems to see them as. Any further questions then for Keith on this assurance document? No, we'll move forward. We'll accept the significant assurance that the ongoing flexibility and the way the team approach this gives the governing body. So thanks for that. Let us move on then to the next item on the agenda, which is, I think, a verbal update from Matt Brown and Deb Cornell on South Tyneside and Sunderland CCG working arrangements. Is this going to be Matt handing over to Deb?
Yeah, so I'm going to start, if that's okay, and then hand over to Deb. So the governing body members will know that we've been working ever more closely with Sunderland CCG for quite some time now, and you'll also be aware that I've been trying to poach Deb Cornell for probably the last 2 or 3 years. So we're really pleased that Deb Cornell's now working as head of corporate affairs for both Sunderland and South Tyneside CCGs. And we've really taken the opportunity to start to bring together the governance and involvement teams across the two organisations to support the way in which the organisations work together already. So I won't say any more than that, other than I'm really pleased to have Deb, and I'm sure Deb will want to pull out some kind of key points about the work we're doing already.
Thanks, Matt. And yes, and say very happy to be with South Tyneside, as I'm a South Tyneside resident, so it's close to my home. So yes, and say pleased to be joining you guys. So yeah, just a quick update really in terms of where we're at, and see, as Matt alluded to, we have got the joint team in place now from the 1st of November, and we're just working through the practicalities of how we can pull systems and processes, etc., together wherever it makes sense to do so. It's a bit of a challenge in the current ways of working, so trying to do everything virtually is difficult, but we're getting there. And I suppose all credit to the team that they've all been very, very positive around the move, and they're all very keen to sort of to get on and do the joint working. I think the other thing, just to sort of run in parallel to the joint team, is the work around the joint governance structure that we've discussed in previous meetings. Running in parallel to this will be a proposal through to the quality and safety committees of each CCGs about establishing a joint committee early in the new year, so that's progressing. And also there'll be conversations taking place around the primary care commissioning committees next, as to if there's any opportunities that we can to do something in common with both CCGs. So yes, it was a good work in progress so far, but we'll keep going, and hopefully in the new year we'll have more of a joined up governance structure in that respect.
Thanks very much. Any comments, questions? Neil, you're leaning in towards the camera, which normally means you've got something to say.
It is. I mean, yeah, it's a great development, and I think you know, we've tried to get ever closer working with Sunderland South Tyneside over the last few months, and there's lots of examples of how we're doing that. I guess it was just whether or not you wanted me to follow on with the. I mean, there is obviously the paper of the Secondary Care Committee, which again is a good example of how we're working closer with our neighbouring CCGs. I don't know if you want me to pick that up just now, Matthew.
Yeah, that's the next item on the agenda with the enclosure. So do you want to maybe let who's going to present that? Would that be Deb? It's got Deb's name next to it.
Yeah. Deb's asked me on text if I can just quickly run through it, because I've been leading on some of the work. So governing body members have been involved in lots of informal discussions. This terms of reference has been round chairs, lay members, executives. We've had joint meetings of the lays and exec GPs last week about this. So a lot of work and engagement has gone in about how we do this. Effectively, this is a setting up a committee which is a formal subcommittee of the 3 governing bodies within the central integrated care partnership. And will oversee the operational delivery of commissioning from secondary care services. We will obviously take guidance from governing bodies on the strategic priorities, and any kind of local place-based arrangements as well will feed into that. Just really to draw your attention on terms of reference to the things that people most are usually most interested in, which is on the delegated limits or authority, which we have put in there of 10 million. 10 million is basically the delegated authorities of the 3 executives across the CCGs put together, and effectively we've got key members of the executives coming together and making decisions together within this committee, which is the rationale behind this. And then looking at the membership as well, just to make sure that everyone is happy with that. So as you can see, there is a good spread of both clinical and managerial leadership from across the CCGs. And I think we've got to some agreement now about what that membership is. There was some comment about whether or not secondary care lay, secondary care doctor lay membership should be involved in this. We've agreed to review the membership and how the committee is working in 6 months, and then we can think about that, because there was some concern raised that we've worked through about voting membership of chairs. We think it's more important that chairs are there, and the involvement of secondary care clinicians. So that's all can be reviewed in 6 months' time. So again, this document shouldn't be any surprise to anyone. It's, I think it'll be a real step in the right direction for us, give us a stronger commissioning voice when we're talking with our FT providers, help us do some of the major transformation across the ICP as well. So I'm just happy to take any questions and looking for agreement of those points, which is the approve the terms of reference, agree to establish the committee from January, the delegated limit of 10 million, and then the delegate to agree the level of delegation, and then obviously the review after 6 months.
Thanks, Neil. I invite comments and questions. I know that John specifically had expressed some reservations around membership in some of our discussions prior to this. I don't know, John, whether you want to raise things here.
I was quite content that we had the discussion outside of this meeting, Chair. Thank you. I think technically it's probably not the purest way of doing it, but I understand the reasons, and I'm happy that it's reviewed in 6 months. So thank you.
Thanks, John. Any other questions, comments, Deb?
It was just to add that and say the terms of reference did go through to Sunderland CCG's governing body on Tuesday of this week, and they did approve them, just so you're aware of that.
Thanks.
I don't think they go to Durham until December, actually.
As long as it's before January, if that's when we're expecting the committee to meet. It's quite important that it's before then. That will be fine. Okay, so absent of any further comments or questions, can we take that as approval to adopt these terms of reference for that proposed joint committee? Okay.
Thank you
very much. Thank you, colleagues. Once again, my screen telling me what I'm going to do next has managed to turn itself off, all this energy saving. There we go. So we've got the usual collection of subcommittee and other committee minutes that come to these meetings. Does anybody have any items that they wish to raise related to those minutes? Nope. Okay, we have the cycle of business, which is really there for information, for people to know what's coming up in the future. I haven't had any.
Sorry. Just a quick note on the cycle of business. Members will notice that actually there are some things that we haven't picked up in this month you would expect us to on the cycle of business, and that is purely because of the different way of working we have under COVID, the financial framework and so on. So we'll have to refresh the cycle of business a little bit. So it's just to note that, Matthew.
Yeah, I think planning for next year was, as we commented on the way that the financial structures are at the moment, we are sort of very much out of kilter with our usual planning cycle, and we'll just have to adapt, as you say. I haven't been notified of any other questions from members of the public coming through, so I hope that means that there aren't any. If anybody has submitted anything that hasn't managed to find its way through to me, then I do apologise. We will get back and respond by email at a later date. Neither have I been notified of any other items of urgent business that need to be conducted today. So I will close the meeting by finally saying farewell to Keith and to Keith Haynes, who has been working with us really since. I was just thinking back, it must be almost 10 years now, Keith, since you and I sat down with a draft constitution for what was called a commissioning consortium at the time under the NHS bill proposals, and started to think through how it could all work. And pleased to say that pretty much everything that we put in has stood the test of time and has proved to be the right decisions that we made together with your guidance back then, and you've stayed with us through all those years, very much valued advice. So whilst Deb moving into the team is certainly very welcome and a step forward, I think, for a lot of the joint working that we'll need, it does mean that we're going to be saying goodbye to yourself, Keith. And I just want to thank you personally for your support over the years, and on behalf of the organisation as well, for all that you've done for the CCG.
Well, thanks very much, Matthew. I've enjoyed it. It's not been a continuous 10 years. I think the last stretch has been about 5, but it's been very enjoyable. Great to work with. I think you've come a long way actually in South Tyneside. I think you've made a great journey, and I've always enjoyed your governing body meetings. Very good luck, good wishes to all of you for the future, because I think who knows what that's going to look like. But perhaps there'll be even more work when the new legislation comes out at some point in the future. Who knows? But good luck to you all, and I've very much enjoyed working with you, and you've come on, I think, significantly in leaps and bounds as a governing body, and certainly the way that you react and your behaviours and the progress you've made in moving the agenda forward has been great and commendable, and particularly as we've heard today, the connectivity with the local authority has been fantastic. So
thanks for those kind words. Can I ask governing body members to stay on the line for a few minutes for our usual time of reflection, and I hope will be one of Keith's lasting legacies to the organisation. I've got a quick hand gone up from Tom before we close the meeting there.
Yeah, apologies, Matthew, and sorry, it's nothing to do with Keith, but thank you anyway, Keith. It's been a pleasure working with you. It was just to say that the government have just announced that the North East has gone into Tier 3, so I just thought I'd mention that before the close of the meeting. A little bit of news to end it by, I'm afraid, but
as you said, Tom, before, not entirely unexpected, and something that we'll be no doubt working with for a wee while to come. All of these tiers moving up and down, hopefully down more than up for coming time. So we shall see, and time will tell. So thanks all for your contributions today. Please stay on the line, and we will do some reflections once Lee's able to confirm that the streaming has ended.